I'd like to thank the AGS Program Committee and Drs. Coleman and Shah for inviting me to give this talk. I have no disclosures. H.G. Wells said that heresies are experiments in man's unsatisfied search for truth. And while I don't think I'll be saying anything heretical today, I do want to discuss experiments suggesting that glaucoma is not only a pressure-dependent optic nerve disease, but it is also a pressure-independent retinal disease. So the evidence for eye pressure independent factors includes the fact that nearly 40% of open-angle glaucoma patients do not have elevated IOP, suggesting that IOP independent risk factors are playing a major role. We also know that low ocular perfusion pressure, both diastolic and systolic, but here I'm highlighting evidence from the early manifest glaucoma trial showing that low systolic ocular perfusion pressure is associated with higher risk of glaucoma progression. And of course, ocular perfusion pressure is not fully divorced from IOP, but we know that vascular factors are likely playing an important role. We also know that the low tension glaucoma treatment study demonstrated that brimonidine, a neuroprotective agent demonstrated in the laboratory, resulted in less visual field progression compared to timolol, despite similar IOP lowering. Glaucoma is also a retinal neurodegenerative disease, and I'll focus on two aspects: compartmentalized neurodegeneration and ganglion cell type susceptibility, and how this information can lead to new biomarkers, including novel imaging and functional assessments. Now, there are many types of ganglion cells, but one functional distinction are the on versus off ganglion cells. The on ganglion cells are responding to light increments, whereas the off ganglion cells are responding to light decrements. And they stratify differently in the inner plexiform layer, as shown here in the red and blue cells. I'll be focusing on two of these types, the on-alpha sustained ganglion cell and the off-transient alpha ganglion cell. And these two represent a nice dichotomy between on and off. In a mouse model of elevated IOP, our group showed that after transient eye pressure elevation for 7 days, after which eye pressure returns to baseline, the alpha on sustained ganglion cells actually maintain their dendritic area and even increase their receptive field radius, whereas the alpha off transient ganglion cells shrink, both in terms of dendritic area and their receptive field radius. However, despite the fact that alpha on sustained ganglion cells maintain their dendritic area, they lose their synapses, and that's quite apparent here based on these heat maps, with red for high density in the control and blue representing low density in the eye pressure elevation condition. And this occurs as early as 7 days, as represented by the magenta curve here. And so we know that synapse loss is occurring before dendritic shrinkage, and that represents compartmentalized neurodegeneration. And that synapse loss is an early biomarker of glaucomatous retinal neurodegeneration. So how can we use that information to look at the inner plexiform layer in novel imaging strategies? There are several groups working on this problem using visible light OCT. Conventional OCT cannot distinguish between the ganglion cell layer or segment between the ganglion cell layer and the inner plexiform layer. So we have the ganglion cell complex. But visible light OCT can now demonstrate these hyperreflective bands segmenting different portions of the inner plexiform layer, much like we see in histology. And in fact, I know that Dr. Gasabi may have spoken earlier during this meeting about their work showing that there may be differential thinning of various sublamina within the IPL in glaucoma patients versus controls. We also know that alpha on sustained ganglion cells are more resilient after eye pressure elevation. This is data showing that they survive, whereas the alpha off transient cells are lost. So the off cells may actually represent the canary in the coal mine, early susceptibility, whereas the on ganglion cells are like the hardy coal miner, much more resilient. And so are these more resilient ganglion cell types functionally impaired, but able to be rescued? We and others have shown that there's early synapse loss and dysfunction, followed by dendritic shrinkage, ERG amplitude and receptive field size loss, axonal transport deficits, and microglial activation, suggesting that IOP-independent neuroinflammation may be playing a role. To look at this dysfunction, our group decided to use the ERG to directly and objectively measure changes in the on versus off pathways. This has been explored with other ERG modalities, and there's evidence that a flicker stimulus can be used to separate the on versus off pathways, with the off pathways being dominated at the higher frequencies shown here in purple. We enrolled patients into a study using the handheld Reteval device to measure ERG responses. And we used a custom-written sinusoidal flicker wave pattern of light, high frequency and low frequency. These are example waveforms from a patient and show that at high frequencies, there is a decrease in the ERG response shown here in orange as compared to the control in gray, whereas at low frequencies, there is no difference. And this was true when we looked at ERG responses as a function of stimulus frequency with greater separation at the higher frequencies. And when we looked at lower than 10 hertz versus greater than 10 hertz, glaucoma patients exhibited a decreased ERG response. And so our current paradigm is that glaucoma exhibits optic nerve damage as evidenced by optic disc and retinal nerve fiber layer or visual field abnormalities. And it is my hope that in the near future, glaucoma will be defined as exhibiting both optic nerve damage and retinal degenerative changes, and that we will be able to measure these with novel functional and imaging studies. So I'll end with a quote from Helen Keller: "The heresy of one age becomes the orthodoxy of the next." And I'd like to thank members of my lab team. Here we're doing a virtual escape room, and highlight Alan Kong. He'll be applying for ophthalmology residency this fall, who spearheaded the ERG project. I'd like to thank you for your attention, as well as my funders.